today it's my pleasure to introduce Dr. Mark Schweizer. Dr. Schweizer is the Dental Director of the Florida Caribbean AIDS Education and Training Center. He is also Director of Development and Special Projects at Nova Southeastern College of Dental Medicine. Dr. Schweizer is a graduate of the University of Maryland College of Dentistry and Nova Southeastern University, Master of Public Health Program. He serves as Clinical Director of the Ryan White HIV Dental Program for Nova Southeastern College of Dental Medicine and is the current Chair of the System of Care Committee and Ad Hoc Bylaws Committee for the Broward Regional Health Planning Council. Dr. Schweizer is also a member of the Executive Committee of the Health Planning Council. He has more than 20 years of private practice experience and has lectured locally, nationally, and internationally on how dental providers can serve the needs of special populations and underserved communities. It is a pleasure to welcome Dr. Mark Schweizer.
Thank you and good afternoon. So basically I'm going to first go over the session objectives. So at the completion of the program, participants were able to, 1, demonstrate the proper steps for a comprehensive intraoral and extraoral evaluation, recognize when medical referrals are necessary for oral health for HIV/AIDS patients based on basic laboratory values, identify and differentiate oral lesions commonly found in HIV/AIDS patients, and describe treatment modalities based on oral health lesions identified. Basically, what we're going to cover today is national and local HIV demographics, lab values and relationships to oral health care, common oral lesions associated with HIV and treatment options, and how to perform an intraoral, extraoral exam. I want to go over some basic demographics of what HIV looks like in the United States today. As you can see, a lot of the HIV/AIDS epidemic is still concentrated in the South, particularly looking at Florida. This is a little out of date, but this still reflects today's population. So obviously Florida is the highest and this concentrated in the South, other than basically New York and New Jersey. When we look at modes of transmission of HIV, still the predominant mode of transmission is male-to-male sexual contact, MSN, followed by heterosexual contact in females, which continues to be a growing population, followed by heterosexual contact in males. So as we're going through HIV and AIDS into the next few years, we're going to see a large change in demographics, and we're starting to see it happen already. When we look at basically race and ethnicity, we see that a big differentiation between females and males. In females, we see that almost 60% of the cases of HIV are in females, okay, and in the Black African American community. A little lower in men, but still a large percentage, and then we're divided up pretty equally or close to equally between whites and Hispanic and Latinos. And that will differ a little from location to location, but when we really look at the female African American community as well as the African community in general, they're really being disproportionately affected by HIV and AIDS. Just some fast facts for you all. Basically, 1.2 million people in the United States are living with HIV infection. What's really particularly actually disturbing and we really need to address is 1 in 5 or 20% are unaware of that they're HIV infected. Men having sex with men or MSN, particularly young black MSNs, are more severely affected by HIV. And of course, like I stated before, by race, black African Americans face the most severe burden of HIV. The greatest increase we're seeing now is in new infections in the age group of 24 to 39-year-olds. So we're really going to look at how we're going to concentrate our prevention efforts in the future. For the federal year 2014, U.S. federal funding to combat HIV totaled almost $30 billion. Of this, about 55% was for care, 10% for cash and housing assistance, 9% for research, and only 3% for prevention. And 22% of the global epidemic has been addressed with this funding. So when we look at we're only spending 3% for prevention, we can see sort of the changes we're seeing in the HIV today. And this is just some recent surveillance data with the leading states. Unfortunately, the state that I live in, Florida, has the highest number, followed by California, Texas, New York, and Georgia. And when we look at the three metropolitan statistical areas with the highest HIV infection and case rates, we look at Miami, Florida, Fort Lauderdale, Florida, and New Orleans, Louisiana. Now, it's always from month to month it changes, so unfortunately we're not in a good race with Miami and Fort Lauderdale. 1 month it's Fort Lauderdale, 1 month it's Miami, but still pretty staggering statistics that we're seeing. What I really want to talk about, and I just want to mention this briefly, is about oral testing and HIV testing in the oral health care setting. When we really need, when looking at combating any type of disease process, we really need to look more at the overall medical model of care and how the dentist will be really engaged with that. Now, the CDC looked at recommendations, and in 2006, they asked for widespread HIV testing. And the new recommendation basically proposed that HIV testing be offered to all individuals ages 13 to 64 in all healthcare settings, and basically on an opt-out basis rather than waiting for patients to request testing. And this basically has brought HIV testing in line with other sexually transmitted diseases protocols and really helps reduce what has been referred to as HIV exceptionalism. There's been quite a few studies that have been done recently about how participants would feel about having rapid oral HIV testing in the dental setting, and the results have been very positive. They've looked at it from the dentist doing it, from the dental hygienist, or even dental auxiliaries performing rapid HIV testing in the dental clinic, and patients seem very responsive. I have a resource for you to look at, but some of the products out there that we can use are Clearview, Multi-Spot, and probably most of you are probably familiar with OraQuick. I know they carry it in Walgreens and CVS. But as we move forward, we really need to look at adding this HIV testing in our traditional health settings, including the dental office. Now, just a quick review of HIV. I'm sure all of you are familiar, but basically HIV stands for, it investigates two types of viruses, HIV-1, HIV-2. Most of the HIV cases in the United States are basically caused by HIV-1. So basically when we use HIV, we're referring to HIV-1. It's a retrovirus, and it basically affects CD4 positive T cells. And as we know, immunodeficient people are more susceptible to a wide range of infections, most of those which rarely occur among people without immune deficiency. And for those of you who may have been working with HIV in patients for many years, you know that this is what we would see initially, rare diseases that we wouldn't really associate with people of age groups or demographics. Infections associated with severe immunodeficiency are known as opportunistic infections because they take advantage of the immune system. Now, also, when we look at defining other illnesses related to HIVs, we need to define AIDS, which is basically based on either a T cell count that's less than 200 or several of the conditions I have listed. And the first one, of course, candidiasis is an oral condition that we often see. Cytomegalovirus, herpes simplex, histoplasmosis, wasting syndrome, Kaposi Sarcoma, tuberculous lymphoma, and PCP pneumonia. And just sort of, I always explain this, so once a patient is defined as having AIDS, even if their T cell count goes above 200, they still keep the definition of AIDS. Now, the oral manifestations of HIV disease are manifold, prevalent, and clinically significant. And our recognition and the management of these oral manifestations remains an important area for study for clinicians who treat HIV-infected patients. Oral lesions may be the first clinical sign of HIV infection and can cause significant morbidity. And basically several of the things that we're going to focus on today is oral candidiasis, oral hairy leukoplakia, and ulcerative diseases. Now, with the advent of effective antiretroviral therapies, the overall prevalence of HIV oral manifestations has decreased. In addition, with the improved long-term health of HIV-infected persons, there has been a renewed focus on the importance of preventive oral health care through regular dental care. Good oral health allows for appropriate eating, speaking, increased quality of life, better self-confidence, social acceptance, and most important, employability. However, dental decay, gingivitis, periodontal disease are common problems for HIV-infected individuals. And causes of this dental decay and disease include inadequate dental hygiene, poor diet, xerostomia, and changes in the immune cells in the salivary glands. Unfortunately, barriers to good oral health still exist. They include the lack of insurance, lack of dentists who are trained or willing to see HIV-infected patients, even for routine care, patients' fear of dentists, and lack of awareness of the importance of oral health care. Now, I just wanted to mention this quickly. You hear this a lot about the HIV transmission in the dental profession. Now, there really is no recorded case. There was a case in Florida. Remember Kimberly Bergalis and Dr. Acer, but that was not just a normal transmission in the dental office, and I won't go any more details at that at the moment. So when we look at the dental profession, here's what we really need to look at and how it relates to HIV. We need a thorough medical history and keep it updated and documented. Patients need to have a blood pressure and pulse at each visit because many patients who have HIV have side effects from many of the medications as well as other medical complications. So often we can diagnose hypertension or some other issue with their medication. We have to do a thorough review of labs, a thorough intra-oral, extra-oral examination, and more important, when we talk about the medical model of care, we need to learn to work with their primary care as well as their infectious disease doctors. So I'm going to share this chart, and I'm not going to go over all of these, but it's available for your review, but this is basically a chart of implications of how we look at lab values related to oral health care. What I want to really point out and really sort of clarify that there is no condition that we would not treat a patient for a dental disease related to their HIV disease. And this is very critical. There is no reason why any general dentist or any practitioner of healthcare can provide care as needed for an HIV patient. The things we need to look at for a dentist in particular, and that everyone should be looking at, is number one, HIV viral load. Now we know that most commercial tests basically we look at non-detectable as less than 20. So what we're concerned about is basically if the patient has been on medication, a hard ARVs, for more than 6 months and their viral load is non-detectable, what is going on? And that's the thing we really have to look at, is really looking at the total overall medical model of care. This is significant because it can indicate the rate of HIV progression and the response to the medication. Of dental significance also is when the viral load becomes is now longer non-detectable, we could see oral manifestations, candidiasis, xerostomia, recurrent caries, even cancers. So again, we may have to ask for additional consultation, but if it's more than 20 copies per milliliter after 6 months on therapy, then we need to maybe talk to the physician. The other test we need to look at that's critical is basically the CD4 or the T cell count. Now again, we talked about it, if it's less than 200, it's AIDS defining. It also indicates immune status and determines therapy irrespective of total lymphocyte count. So in general, HIV disease is progressing if the CD4 count is going down. And if it's less than 200 again after 6 months of ARV therapy, again we need to try to figure out why. I've seen this many times in my practice. You see lab values that are really not what you would expect. Is the patient not taking their meds, or they're not taking it as directed? Did they lose their health insurance? Did they sell their meds to buy some type of illegal substances? These are things that we deal with every day. Now, the other lab value I really want to talk about, which really does affect dental treatment, is the ANC, or absolute neutrophil count, which is basically the neutrophil percent multiplied by the white blood cell count. Okay, and this is the one case, again, we would not deny treatment, but we probably want to pre-medicate the patient because of susceptibility to infection. So if the absolute neutrophil count is less than 500, then we want to really pre-medicate the patient with some type of antibiotic before any therapy, especially endodontic or root canal therapy, things like that. So extraction. So again, if the patient has neutropenia for a long term, okay, again, we want to bring in the medical model of care and speak to the physician. And then the other thing I wanted to mention is basically the platelets, okay, and this really needs to be addressed, especially if you're doing an oral surgery risk, post-op bleeding complications, and it's possible the patient may need a platelet transfusion. So again, it's always best, I think, in treating any patient with any type of medical condition is really to build a good relationship with the physician. So just a little about these lab values. Remember, they're different for each lab, so please look at that, okay, and be sure that you look at what those lab values are, okay, and the antibiotic coverage is not based solely on a patient's HIV status and should not be based on CD4 and lymphocyte counts alone. Okay, so really, again, a thorough medical history. Be careful about initiating procedures that may cause bleeding or bacteremia. That includes scaling and root planing. Maybe we could pre-medicate. We could irrigate the sulcus with an antibacterial like chlorhexidine prior to the tooth extraction or gingival flap procedures. And just some other data that the new studies are suggesting that the CD4 percentage may be a better indicator of disease progression than just the CD4 count. And then below, I basically gave the antibiotic therapy, basically amoxicillin 1 hour before dental therapy if the neutrophil count is low. But remember, many patients are on long-term antibiotic therapy as a treatment against pneumonia and TB, so please take that into account before you prescribe additional antibiotics. Let's talk about the intra-oral, extra-oral exam. And I'm going to be showing a short 3-minute video. This is something that all healthcare practitioners should be doing on a routine basis for their patients. Because again, even in today's world with all the medications we have and the treatment, we're still seeing quite a few number of oral lesions that are associated with HIV.
In this instructional video, we will demonstrate how to perform the proper technique of the extra-intraoral examination. Observe the patient upon reception. The visual examination, you're going to check the extraoral tissues. These include the forehead, the eyes, cheek, nose, lips, and neck. For the palpation examination, the clinician will don examination gloves. Bilateral palpation of the submental area, submandibular area, preauricular nodes, post-auricular nodes, occipital nodes. The anterior and posterior chain of the cervical lymph nodes along the sternocleidomastoid muscle right side and left side. Lastly, the nodes of the neck, the supraclavicular nodes, the clavicle area to the shoulders. You will palpate the thyroid gland. Ask the patient to swallow. A bilateral palpation of the TMJ. Ask the patient to open and close. The parotid gland, have the patient clench. Now you will wash or sanitize your hands and apply new gloves. Visual examination, observe the labial mucosa, upper lip and lower lip. The buccal mucosa, right side and left side. The palate, hard and soft. The posterior pharynx, patient says ah.
Ah.
The tongue and floor of the mouth. Palpation examination. The labial tissues, upper and lower lip, retract with your index finger and thumb. The buccal mucosa, by manually the index finger and the middle finger of the opposite hand, right side and left side. For the palate, use your index finger to palpate the hard and soft palate. A piece of gauze for the tongue. The clinician will use the gauze to grasp the tongue, checking the lateral borders, the dorsum and ventral surfaces, also palpating the posterior and the middle third. The floor of the mouth, the clinician will instruct the patient to raise the tongue as they palpate from posterior to anterior on both sides. This concludes the extraoral and intraoral examination.
Okay. Anyway, we're going to move on to the next step. Again, as you see, this video is something that you all can do very routinely. It's basically a 3-minute process, and it's really important. It just as you basically do a quick sweep of the mouth and look for oral lesions. Salivary gland disease associated with HIV can be present as xerostomia with or without salivary gland enlargement. Now, what we originally thought was basically it was the result of the medications which caused the xerostomia, but basically we're seeing that there's HIV virus damages the salivary gland in addition to the medication. So basically an evaluation of the carrier's risk and frequency of home care instructions and periodontal disease should be really looked at carefully. So in addition to the HIV virus attacking the parotid gland, patients have dry mouth because of medications such as antidepressant, antihistamines, and anti-anxiety drugs. So basically, patients with xerostomia have a higher risk of caries. And I had done a sort of a brief survey of the patients we saw over a 6-month period as new patients. And basically, the average number of caries in the patients we saw was somewhere between 12 and 15 caries lesions, which is very large. And these are just some pictures of some patients who have rampant caries, as well as the dry tongue, which could be very uncomfortable to the patient, affecting their eating, speech, and multiple other things. Some of the treatments you could try, there's salivary stimulants such as sugarless gum or sugarless candies may provide some relief. Please stay away from acidic foods. A lot of people will say use a lemon drop, but the problem is that it has a lot of acid. There's also some products, Biotine, Eclipse, Extra, Orbit. Those are some gums that you can use. There's Biotine Oral Balance. There's a mouth spray, Salivary, Oral Lube. The list is there. And then probably only with the consultation of a physician, I would look at some of the pharmacologic stimulants such as pilocarpine hydrochloride and cevimeline hydrochloride. But I think I would try all the others before I would recommend. And again, if you're going to think of pharmacological stimulants, I definitely would consult with the physician. So the other thing you can do is because of the dry mouth, you're going to have an increase in caries. So I would definitely recommend putting the patient on a fluoride rinse. Many of those can be bought over the counter. There's also prescription fluoride rinses, and encourage all your patients to visit the dentist routinely, probably 2 or probably 3 times per year. And some of the over-the-counter products, you've probably seen these, are ACT, FluoroGuard, Prevalence 5000, Oral B, Neutrophil. Also, we use fluoride varnishes in the dental setting, help prevent caries, and again, brushing, flossing, and using a tongue scraper are really critical to maintain adequate oral hygiene. One of the things I wanted to show you is the prevalence of meth mouth in HIV/AIDS. And there's studies that show there's a higher prevalence of methamphetamine use among men having sex with men than among the general population. For example, a study showed of urban men ages 15 to 22, 20% of the participants reported having used meth during the past 6 months. So in addition to the effective carries, all the other effects of drug addiction and homelessness and the other things that surround it are very critical for us to look at. So we're going to start with bacterial lesions, and basically periodontal disease is very common in both asymptomatic and symptomatic HIV patients, and there's basically two forms. One is what we call rapid and severe condition called necrotizing ulcerative periodontitis, and actually there's something that comes up with this which is called a linear gingival erythema. It's basically a red line around the gums, which you see on the picture on the lower left, and this is a feature that is very different from those in non-HIV infected patients. So in patients who are HIV infected, you're more prone to see the LGE, or the linear gingival erythema. So if you do an oral exam on a patient and you see that, it should probably raise a red flag. And these are some other pictures. Periodontal disease affects, there's bone loss, redness of the gums, loss of teeth, and subsequent infections. So how do we treat this? So there's the necrotizing ulcerative gingivitis really requires aggressive therapy and tissue debridement to remove the pathogens from the tissue. We can use povidone iodine as an irrigant. The most common drug that's used is metronidazole, 250 milligrams 3 times a day, 5 days. There's some antimicrobial rinses, chlorhexidine, 15 cc's 2 times a day. Regular maintenance is very important every 3 months. Regular periodontal probings every 6 months. Radiographs, extensive home care instructions, oral aids, and documentation. The problem with the NUG is that it's very rapid and it can cause a lot to bone loss and loss of teeth very quickly. So we really need to address this. That's why we do aggressive therapy. Periodontal disease in general involves the use of scaling and root planing. Again, metronidazole. I've listed some other antibiotics. The reason I'm talking about concurrent antifungals, as you may have noticed, is that when you change the bacterial flora, a lot of times you'll see outbreak of Candida, which needs to be treated. Again, regular maintenance every 3 months, regular probings, extensive home care instructions, oral aids, and I mentioned documentation several times in these slides because you really need to look at your baseline and to see how the patient is moving, because if you're not watching the progression of periodontal disease, it can move very quickly. It can lead to a quick tooth loss and subsequent infections. The next lesion I'm going to talk about is candidiasis. And this is frequently seen among HIV-infected individuals and is an indicator of immune suppression. It occurs most often in patients with CD4 counts less than 200, and the most common form of the candidiasis is what we call Candida albicans, is the most common type involved. And the introduction of widespread use of effective antiretroviral therapy has led to a marked decrease in the prevalence of oral candidiasis. Although HIV-related immune suppression is typically the most important risk factor for developing oral candidiasis. Other causes include antibiotic use, corticosteroids, chemotherapy drugs, but by maximizing immune status with effective antiretroviral therapy, most of candidiasis cases can be avoided. So we talked about that a little bit. Again, immune suppression is the most important risk factor for developing candidiasis. There's several different types, and I'm going to go through those quickly. We have pseudomembranous, which is the most common, or what we commonly call thrush. We also have atrophic, which has a reddish appearance. We have angular cheilitis, which is also a form of candidiasis. We have hyperplastic candidiasis, and so let's talk about the treatment. Now, some of the symptoms that the patients may come in with is they may say that they have a burning sensation in their mouth, altered taste, So basically, this is how we treat it. We use oral fluconazole as a drug of choice for treating it, and basically it's easy to use, it's convenient, and it's very well tolerated. Topical therapy reduces the risk of systemic drug exposure and adverse effects, and also is considered an acceptable first-line therapy for mild to moderate oral disease. We can also use topical therapies, include miconazole, buccal tablets, clotrimazole trokes, or nystatin suspension. There's all types of things. There's also oral solutions that are available. The problem with the itraconazole or prostaconazole oral solutions, they don't work as well, and then there's capsules, and they really are not really taken up well in the system. Systemic ketoconazole is not recommended due to reduced efficiency, increased risk, or drug-drug interactions, and poor tolerability. And like I've said before, okay, I would be really careful about giving any type of systemic, especially IV drugs, without the consultation with the physician. And usually treatment is usually given for 7 to 14 days and reevaluated on a regular basis. Again, the diagnosis is usually based on clinical appearance, but you can do smears, and you can do a fungal culture if you're not getting a response. One of the other things I wanted to mention is called oral hairy leukoplakia. Okay, and this occurs in up to 20% of HIV-infected individuals, typically among those with moderate to advanced immunosuppression. And it's an interesting sort of indicator of how the CD4 is moving. So 40% of a group who had oral hairy leukoplakia went on to have CDC-defined AIDS within 2 years and 67% within 4 years. So it's a really important to look at. Basically, you see raised white corrugated lesions, most often on the lateral aspect of the tongue. Unlike the candidiasis, which we saw before, oral hairy leukoplakia cannot be scraped off with a tongue blade. So that would be a good diagnostic tool to look at. If you can't scrape it off, it may be oral hairy leukoplakia. They can do a biopsy. There's other things they can look at. Usually, it comes about because there's problems with the ARV therapy. So usually, oral hairy leukoplakia resolves. Although you can use a valacyclovir, you could use a podophyllin resin combined with acyclovir cream, and we often see this as a later sign of HIV disease, okay, and an important sign of immunosuppression. So again, oral exams are very important. We're all aware of herpes simplex, causes both primary and secondary or recurrent disease in the oral cavity. We can see it on the gum tissue, we can see it on the roof of the mouth, we can see it on the lips, okay, we can see it on the face. So again, a very thorough intraoral, extraoral exam. Okay, lab testing is usually recommended, and this is done through a DNA PCR or viral culture and antigen detection. Okay, treatment, oral valacyclovir, famciclovir, or acyclovir for 5 to 10 days. Okay, again, intravenous acyclovir for severe mucocutaneous disease, although I would not be doing this without the consultation with a physician. Some patients, as we're aware of, are on long-term treatment, and they could be on the acyclovir long-term for daily suppressive outbreaks, and you can do this if they have constant outbreaks. So what you would do for that is you use acyclovir 400 milligrams twice daily, famciclovir, and then also it talks about valacyclovir. And basically it's twice daily or recommended for patients with chronic suppressive therapy in HIV patients. Again, before I would recommend doing this, I would consult with the physician. Okay. One of the things we see very common, I've seen a lot of discussions even among the AETC about abscess ulcers, and I really wanted to go over this pretty carefully with you all. It also can be called abscess stomatitis, and it affects up to 15% of HIV patients, and basically even with all the drugs, we haven't seen a significant change in recent years. Now the cause of abscess ulcers is sort of unclear, but it could be an overstimulation of tumor necrosis factors. But when we compare this with abscess ulcers in immunocompetent patients, patients with HIV typically have oral ulcers that are more extensive, more frequent in nature, and slower to heal. Okay, so basically this is diagnosed basically on clinical presentation. You should exclude other things like syphilis, neoplasms, drug reaction, Okay, Herpes Simplex, and again, for the herpes, you could do a test, but basically this is usually just by exclusion. Often these are very, very difficult to treat and very recurrent. You can use topical anesthetics for the discomfort, topical corticosteroids combined in a dental paste, because the problem is you need this to stick. Okay, again, if you have severe lesions, okay, you can get systemic therapy, intralesional therapy, but again, this should be done strictly under the supervision of a physician or probably by a physician. Again, like all the other conditions I've talked about, antiretroviral therapy is a critical component in treating abscess stomatitis as well as the other diseases. Now, there is some studies that show that topical tetracyclines may reduce the severity of ulcerations, but they don't alter the recurrence rate. So basically, you could do a doxycycline capsule administered in the mouth. You rinse for 3 minutes, or a tetracycline 500 milligrams with a nicotinamide 4 times daily. It may provide some relief and reduce ulcer duration. But again, it doesn't affect the recurrence rate. There's some other things that are being used, and then you can just review these. You can do doxycycline rinses. Some people report that if they eat a lot of acidic foods, they would break out. So some of this is just trial and error with abscess ulcers. But it's a really difficult thing to treat and very painful and difficult for the patient because, number one, it's discomforting. It may alter their appearance, affect their eating. They may not even take their regular scheduled medications because of the discomfort in their mouth. I want to mention a few other things. Something called IPP, which is idiopathic thrombocytopenia purpura, and this is something that may be an initial indication of HIV infection. And again, this is like some of the others, a process of exclusion. You need to look at the abscess ulcers. Did the patient bite their lip? What occurred? But this is something we often see in initial infections and HIV infection during the initial infection phase. So if you see a patient come in with this and they have these red dot lesions on the roof of their mouth or these purple lesions on their lip or on their gums, it's probably a good place that maybe where you could sort of introduce the HIV testing or quick in the dental setting. A couple other things that I wanted to hit on basically here are human papillomavirus. And we've actually, in this case, oral lesions associated with HPV have increased in the era of effective antiretroviral therapy, and it's also associated with a lot of head and neck cancers. So oral HPV infection is common among HIV-infected individuals, particularly among men who have sex with men, and these infections more frequently involve the oncogenic subtype. And basically, studies have shown an oral HPV prevalence of 20 to 40% of HIV-infected men compared to a prevalence of 6.9% in HIV-uninfected men and women. And these oral warts can look cauliflower-like. They can be spiked, raised, flat surface. They could be white. They could be red. They could be the color of the normal mucosa. You'll often see them at the base of the tongue or the tonsillar region or the lips, and they can be routinely missed on routine oral exam. So again, and on these lesions in particular, it's hard to diagnose between benign and malignant lesions based on the exams. And basically the diagnosis of this is also basically made on the clinical appearance, but if needed, a biopsy can confirm the diagnosis. And what I really wanted to talk about here is when we actually look at biopsying lesions. And, just in my experience of treating HIV patients for the last 25 to 30 years, a lot of lesions that I would think that are benign, or maybe we've something considered a pizza burn or something similar, ended up being a malignant lesion. So my recommendation is that basically, if you see something in the patient's mouth and you're not sure what it is, I would have the patient return in a week to 7 to 10 days. If the lesion is there, please have it biopsied. It's not worth taking a chance. Now, there is no clear standard treatment for the HPV virus. Sometimes they do surgery, laser therapy, cryotherapy, but basically the treatment is basically based on the location of the lesion, the extent of the disease, and of course whether the lesion is malignant or not. And the last thing I wanted to cover basically is Kaposi Sarcoma. And this is basically a vascular tumor in the early era of HIV. We saw this constantly, and it was most frequently associated with oral malignancies with a peak incidence among men who have sex with men aged 25 to 59. So we're still seeing this. So because patients are living longer, the frequency of this malignancy in people who are having problems with their immunosuppression has increased. Okay. However, the rates, so we're seeing more malignancies, but we're seeing a decrease in lesions. I want to go over that again just to clarify. So because patients are living longer with HIV, the frequency of malignancies has decreased, but the rate of actually the lesions has decreased. And basically, these are oral lesions. They're red. They're on the hard palate. They can be macular, raised, or ulcerated. And frequently patients will have not only intra-oral lesions, but extra-oral lesions, legs, arms. So be sure if you're in an area where patients are wearing long sleeves and long pants to please take a look. And basically, the diagnosis is basically, they basically do pathology and they look at it, and then I'm not going to go over the treatments per se. One of the things I wanted to mention is something called magic mouthwash, and this is talked a lot about in the pharmacological journals, but a lot of these lesions are very uncomfortable for the patients. And this is basically, there are many formulas, but the one has worked best in my hands is basically viscous lidocaine, diphenhydramine, hydrocortisone, tetracycline, and a nystatin suspension. Okay. Basically, the patient uses it every 4 to 6 hours. They hold it in their mouth 2 minutes and spit. You also can swallow it, and you don't eat, drink for 30 minutes. So in patients who have uncomfortable lesions, this has, for many patients, this works very well. We're all aware of social issues and legal issues related to HIV. We're still having a lot of discrimination, the barriers to care, employment, financing, housing, family issues, religious issues, cultural barriers. We need to always respect patient confidentiality and ethics. Issues with immigration and end-of-life issues should always be addressed whenever dealing with a patient in the oral health care setting. Just some quick recommendations for treating HIV/AIDS patient. So the magnitude of the viral load is not an indicator to withhold dental treatment for the patient. High viral loads may be present in patients with early asymptomatic disease, while lower viral loads can be seen in very advanced patients on suppressive antiviral therapy. So knowledge of these markers can tell the dentist the general health of the patient and the risk of progression, but in no way influences the patient's treatment. So the dentist can play an important role in reminding patients of the need for regular follow-ups, monitoring. It's recommended from the oral health care setting is that the CD4 and viral load determinants be done every 3 to 6 months so we can just monitor the patients carefully. As far as antibiotic prophylaxis, there's no need for routine antibiotic coverage to prevent bacteremia or septicemia. So when the HIV infection is well controlled, we talked about giving antibiotics when the neutrophil count is below 500, but otherwise I would consult the patient's physician regarding the need for antibiotic prophylaxis for dental procedures. Treatment considerations, we need to look at bleeding tendencies, platelet counts. We need to look at how long we keep the patient in the chair. We may want to, in some cases, you may want to do more procedures because of time. In some patients, depending on the medical condition, you may need to spread the patients out. In patients with severe bleeding conditions, you may want to treat them safely in a hospital setting or an outpatient clinic. Things like deep block injections should be avoided with patients with a recent history of bleeding tendencies, and you really need to look at the patient and see how long they can withstand the treatment and the amount of time, because the last thing you want to do is to discourage the patient from getting routine dental care. And one of the other things you can do if there's going to be bleeding or possible infection during procedures like scaling and root planing, you could do a pre-treatment antibiotic or antibacterial rinse like chlorhexidine. I recommend every patient who has HIV or AIDS is on a 3 to 4 month recall schedule. Number one, to monitor oral health care changes, to look at their immunosuppression. We talked about patients with oral lesions should be assessed in a timely manner. Remember, if you see something and you come back in 2 weeks and it's still there, please have it looked at by an oral surgeon, a pathologist, have it biopsied. Again, monitor patients for caries, periodontal disease, soft tissue lesions, salivary disease. Encourage a positive, proactive attitude for the patients. You know, we tend to speed through home care instructions very fast, but you really should take your time to get to know the patients, talk to them about options that are available. In patients that may have some neurological problems holding toothbrushes, you should look at electric toothbrushes, other things that can help them, and basically schedule appointments at appropriate times and length based on patients' needs. A lot of our patients, the morning is their worst time, so definitely try to schedule some of their patients in the afternoon. You know, 8 o'clock morning patients don't work well for a lot of the patients. It takes a lot to get up and get going in the morning. And then the other thing I wanted to mention is there's a great resource that we have. There's a pocket card that many people have worked on. The new version will be updated soon. Please look at that pocket card. It has a lot of the same information. And just a few sort of summary points I wanted to go over is that basically periodontal disease especially, which is very, very common in HIV patients, even when they're well controlled, have undetectable viral loads, high CD4 counts. There can be signs of other chronic health conditions like diabetes, other bleeding disorders. So routine dental care and hygiene are essential components of good oral health. Again, oral candidiasis unfortunately still remains a common opportunistic infection among HIV-infected individuals. In some cases, we'll see the ones that are resistant to fluconazole, which can complicate their management. Oral Hairy Leukoplakia is really something we can look at and can really look at how the underlying HIV and effective Antiretroviral Therapy is doing. And again, in treating all of these treatments for the patients, okay, Antiretroviral Therapy is the most important of treating any of these diseases. So very important that you really engage, again, the medical model of care for the patients, and be sure that you're fully engaged with their physicians, their case managers. There's many case studies I can tell you that I've had patients come in where I look at their labs, the CD4 is very low, the viral load is very high, and and the physicians may not be even aware of it. It may be a fact that they've lost their housing, that they've, had other issues in their life. So we really need to be really, really careful and be sure that we engage the patients with their physicians, their case managers, their oral health care providers, their caregivers, their family in any way we can. Fortunately, patients are living longer and longer with HIV. It's becoming much more manageable, but as a result, it's creating many more issues. And just sort of a quick story, I was at a planning council meeting the other day, and we were talking about housing for patients with HIV. And we're having quite a problem because when housing was initially set up for patients with HIV, we thought it would be very short term. Now we're looking, because fortunately people are living much longer and living, full lives. Now housing is becoming more of a problem, and we don't have a way to address it. So the same thing with oral health care. We may have not been as concerned in the past of how important it is for people to be engaged in their oral health care, but now as life expectancy is extended dramatically, we need to look more and more on how we can engage the patient in keeping healthy from all aspects, including oral health care. Thank you very much.
Thank you, Dr. Schweizer, for the presentation. I have a few questions from the audience. The first question we have from the audience is, can you give us some pointers about people living with HIV that have dentures? What kind of recommendations would you have for them as far as oral health exams, and how often should they visit the dentist?
Okay, so basically people who have dentures should be treated like any other patient. They should be seeing the dentist once a year. okay, again, to do a oral health exam. One of the things we see is that because sometimes patients don't take out the dentures at night because of vanity, we'll see a lot of candidiasis, both inside the denture and in the mouth. So proper instructions should be given to the patient about how to clean the denture. Also, a denture is not forever. The gums are always changing. So really the lifespan of a denture is really, I would say, 3 to 5 years as patients lose weight, as patients gain weight. If you have a poor fitting denture and it creates a denture sore, it is a source, especially with immunosuppression, to lead to possible some type of either ulcerative lesion, which will not heal, or even could go on to become a malignant lesion. So I know that we have challenges because Medicaid in many cases pays for a denture once in a lifetime. Unfortunately, they're not really, they don't know all the literature, but patients who have dentures need to be routinely seen every year. And when your patient has a denture sore or their denture is loose, the solution is not always necessarily a denture adhesive. In most cases, especially for an upper denture, it should fit well. Lower dentures are a little tougher, but upper dentures that need adhesive probably means that the denture either needs to be remade or relined. And also, denture teeth wear. So if the denture is not fitting well and the teeth are worn down, it's going to decrease their eating efficiency.
The next question that we have from the audience: what are your thoughts about people living with HIV who have multiple cavities? When would you suggest that treat the cavities versus full extractions and dentures?
Okay, so I do what's called when I write a treatment plan for a patient, I do 2 steps. So one is what I would call a disease-controlled treatment plan, which would be to, number 1, get the gum tissue healthy, get as much of the disease eliminated. I think, especially for the lower teeth, the mandible, as we call it, removing all the teeth is a very bad decision, because basically the only thing that holds, on an upper denture, we have the suction of the hard and soft palate, which keeps the denture in, but in the lower, it's basically gravity. And the only reason you actually have bone in your mouth is to hold teeth. So once the teeth are gone, the bone goes away. The makeup of the bone on the upper arch and the lower arch are very different. So the lower arch bone, once the teeth are lost, the bone dissolves away. And basically you'll end up with a flat table, and you'll have a denture that slides around. And we have lots of options. I mean, implants, of course, is the ideal option, but we can often save just 2 teeth with root canals and just leave the roots buried under the gum, which will actually help retain the bone so the denture is more comfortable. So yes, we have to look at each case individually, but I think that to retain as many teeth is very important. Because also look at the emotional aspect. How about you have someone who's 45 years old, and now you say basically you're going to have to take out 30 teeth. So you have to look at the emotional state of even when you have that discussion with the patient, look at the emotional state. How can the patient tolerate that news? How could you maybe phase the treatment? And maybe they will need a full denture, but let's move them to a partial denture for a few years, and then if we have to, move them to a full denture.
The CDC stated that the ACER transmission was linked, but the route was never determined.
Correct. Okay. There's a lot. I mean, remember that was very early in the HIV world. They're not really sure. I mean, they know that Dr. Acer was HIV positive, but if you look at that's one case, and we no longer have any other cases of a patient having HIV transmitted in the dental office. There's obviously something wrong. I mean, there's all types of stories out there, but I think it was also a different era. Back then, dentists weren't routinely wearing gloves and masks. Equipment wasn't being sterilized properly. So there's so many pieces that could have come into that equation that we're really not sure. All that we do know is there's no other case since then where a patient has become HIV positive through routine dental care. And that pretty goes across medical care as well. There's very few cases of transmission. And I'm in a setting where I work with students, And, like I say, that 1 in 5 not being diagnosed, those are the ones I'm more concerned not being diagnosed. I'm more concerned about. I would rather know a person's HIV status, because if they're under treatment and their viral load is suppressed, their chances of transmitting not only in the dental office, but actually just, in whatever, they're involved in, whether it's sexual transmission, IV drug use, is diminished. It doesn't mean that they can't transmit, and I want to make that very clear. And we're seeing that a lot actually in some of our data, that people are thinking because they're non-detectable they can't transmit the virus. So again, as a dental practitioner, we need to engage the patient in all aspects of their care.
The last question is, how does one manage an emotional crisis from a positive fast test for an HIV in the dental office?
Okay, so if you do HIV testing in the dental office, well, first of all, I would never be testing unless you're really, there's a lot of programs, a lot of the that have like counseling sessions. You would definitely need to get some experience in counseling. You couldn't just say, I'm just going to give the test, because there's a lot of things. Some of it's the pre-test counseling, which is still very important. So you need to assess risk, and then the post-test counseling. I think the most important thing to prevent panic in any setting, if you're giving HIV test results, because I also have done that for many years, is to really have resources available. So, here's where you go for this, here's where you go for that, here's how you get this. And I think that's really the important part, is linking patients to care and be sure they're retained in care. So in any setting when we're managing a test result, you can't just say you're positive and see you later. And just one quick thing I wanted to mention, I've been, working with HIV for many years, and I have gone to several sites doing training, and so if anybody is interested in additional training or support, or you need a consultation for any case in particular, please be sure you contact the AETC and we can help you out.
The Florida Caribbean AIDS Education and Training Center's mission is to ensure that physicians, nurses, nurse practitioners, physician assistants, dentists, pharmacists, case managers, and other healthcare professionals in Florida, Puerto Rico, and the U.S. Virgin Islands receive state-of-the-art information, training, and consultation on the prevention, chronic disease management, and treatment of HIV and AIDS. Funding is provided by the HIV/AIDS Bureau of the Health Resources Services Administration, U.S. Department of Health and Human Services. The Florida Caribbean AIDS Education and Training Center provides a variety of HIV/AIDS education, training, consultation, and resources. Visit our website, www.fcaetc.org, to learn more. Stay in touch with us by joining our mailing and email list. You will receive notices about upcoming educational opportunities, as well as new and updated HIV/AIDS resources. You may also sign up to receive our HIV CareLink newsletter. Visit our website, fcaetc.org, and click on Join Our Mailing and Email List at the top of the homepage. Be sure to also connect with us on Facebook, Twitter, LinkedIn, and YouTube. The Florida Caribbean AETC provides consultation services to clinicians in Florida, Puerto Rico, and the U.S. Virgin Islands. If you have questions related to the content of this program, or would like consultation on the diagnosis, prevention, and treatment of HIV/AIDS and related conditions, we would love to hear from you. We also offer consultation on the interpretation of resistance test results. Visit www.fcaetc.org/consultation to ask your question today. The Florida Caribbean AIDS Education and Training Center provides pocket-sized treatment guideline resources that detail the federally approved HIV/AIDS medical practice guidelines, such as the adult antiretroviral therapy, hepatitis, pediatric antiretroviral therapy, adult opportunistic infections, tuberculosis, and pre-exposure prophylaxis, non-occupational post-exposure prophylaxis, and occupational PEP. In addition, we have summarized common practices for the post-exposure prophylaxis in pediatrics adolescents. We have also developed resources that provide an overview for treatment of sexually transmitted diseases in HIV-infected patients and therapeutic agents for oral manifestations. Visit our website to download or request copies of these resources. The Florida Caribbean AIDS Education and Training Center provides web-based educational opportunities to increase the knowledge and skills of HIV healthcare providers. Live and on-demand options are available. Visit www.fcaetc.org/education for more information. Florida Caribbean AIDS Education and Training Center, Project ECHO, provides a web-based didactic presentation on a current HIV treatment issue based upon current Department of Health and Human Services and other accepted treatment guidelines. Project ECHO also provides an opportunity to discuss case presentations submitted by participants and an opportunity to network with both your peers and HIV experts. All members of care and treatment teams, including case managers, are welcome to participate. Information discussed is targeted at providers with basic or intermediate HIV/AIDS treatment experience. Choose from 4 session types. Visit www.fcaetc.org/echo to view upcoming sessions and to register. If you're located outside of our region, the Clinician Consultation Center provides consultation services via the phone numbers listed here. Or you may also visit www.nccc.ucsf.edu for more information. To locate the AETC in your region, visit www.aidsetc.org.